I will go through the clinical trials to clinical practice. So what guideline we use here in UAE? We use all four guidelines from NCCN is the top of it. And sometimes we use MSMART and Emory algorithm, and sometimes expert online. And we are talking about refractory. So what NCCN say, depending on the Velcade refractory or linear refractory, we have a lot of option. The thing is how to choose and how to sequence. The sequence is there. If lenalidomide refractory, then use KRD, PVD based. And if refractory to lenalidomide, then we use DPT and DKT based. The important thing is when relapse of all three triple refractory, then what we do. And just to highlight simple definition, what is the definition of the refractory? Means the patient disease progress while on or within 60 days of completion of the therapy, we name as a refractory disease. Now, going to the case, this is a 50-year male who was admitted internal medicine with a history of backache, lymphadenopathy. He had CBC, had cytopenia. So that's why they call us. And we found it is not only pancytopenia, but the patient has low albumin, high LDH, high calcium, and high protein. And the film revealed he has cytopenia and Rolex formation. And the most important thing, he had infection in the chest. So they found in the CT there is soft tissue swelling in the rib as well. Now we did bone marrow confirmed it is 50% plasma cell. And the factors we do A, B, C, D, albumin, beta 2 macroglobin, and cytogenetics, which was actually triple positive, high risk, very high risk category. So it is IgG, kappa, multiple myeloma, stage 3, very high risk, severe pancytopenia. So the question is what we should do in this patient. This was in 2023. Now, the important thing in NCCN guideline, if you see, the best thing is you can give here, the sooner is better. DARA KRD is the best based on the master and Manhattan trial. So in this patient, we started with the aggressive quadruplet DARA KRD, and here you see key calcium is improved. And here you see with the first cycle, that was light chain was 8,000, reaches to the 2,500. This was good so far. And if you see for the first cycle, then second cycle, then third cycle. After the third cycle, actually, we noticed again the light chains started to increase. Now, what we should do, it is something which is alarming if the patient is on therapy. So it is really refractory to disease. This is the question. If it is really refractory disease, then we discuss this case in our forum that what should we do in this patient? Should we use to label as a triple therapy refractory? Then it can be ESA-based therapy, or should we use lymphoma-like regimen like DTPS and followed by stem cell transplant, or should we go CAR-T and bispecific, which we're discussing now, triple refractory. Now, a lot of discussion was done in NCCN guideline. We found that it's better to go for ESA-based therapy. So we actually, here, patient went for stem cell collection as well. And we decided to start the ESA-PD. But what happened during stem cell collection, we found the stem cell center told stem cells collection was not possible. Patient has very low stem cells. So it's better, don't give POMA too much as well. This is problem. Then we decided, again, we discussed in our international myeloma group, then we decided it's very difficult to say that this patient is triple refractory. Why not we change just Revlimid to cyclophosphamide? It will help us to stem cell collection as well to see the response. The good thing is after 2 cycles DARA KCD, the patients, you see the profile again went down. This is the light chain went up to 1,200, but after 2 cycles again it's progress. Now the thing is, what we should do in this patient. Again, going back, should we continue this one and just to treat more, make it patient harder and harder, or should we give lymphoma like regimen like DTPase and patient should go for autologous transplant, or why not we should do 50 to 70%, which Dr. Maria has shown, bispecific antibody. Then what should we do? If you open the NCCN guideline 2024 version 1 would show indicating clearly that if for prior therapy you can use teclistamab, and these are all 4 which we have given in this patient, anti-CD38 DARA and PI immunomodulator. We have given to this patient actually 4 all the treatments. So this patient is eligible for this. So in this patient, actually, we decided we start with a bispecific therapy without delaying further and treating harder and harder and making the patient's life difficult as per data is indicating. So this is one patient. And second patient, I will go just quickly. This is a 50-year male. In 2017, actually diagnosed. The patient went for VRD in those days, and patient went high-dose chemotherapy, autologous transplant. Then patient was given double maintenance VR, and he actually enjoyed 2.5 years, but again, disease progress. So then when, as per definition, when patient on VR, I would label as VR refractory because disease progress, then we give this patient Kendall-based trial, which is DARA-KD based, and he took actually 1.5 years. It went very well. Then again, disease progress. Then what should we do? Third line, we give him ESA-PD, and then you can see ESA-PD just for 6 months. It went well, but again, now as you see, more you give, you give the multiple myeloma, it is very difficult to treat the patient. It becomes harder and harder. Now it's going to difficult. And this is the fourth line in this patient. You can say he has taken penta or hexa type of therapy, has taken refractory to all. This is again, the patient is eligible for bispecific therapy. So with this, I end my 2 cases. As we know, without data, you are just another person with an opinion. No, we have data, as Dr. Maria has presented. We have data. Response is, 50 to 70% of the bispecific. So that's why do we choose bispecific therapy? Because of that reason, easy to give on the shelf, and it is available. We don't have CAR T-cell therapy, and patient in both, as I've shown, they are not even now going for autologous transplant. So that's why in those patients, we have a plan to give bispecific therapy. Thank you very much, Dr. Marashi.
Thank you very much, Dr. Amar, for your case presentations. And I think now we will open the floor for questions. Yeah, we try to take the questions which are related to today's talk. So I think that we will concentrate on those questions first. And then, so Amarlal, your case was, first case was relapsing very fast. Why? What was the cytogenetics of fish for this patient?
Yeah, it was, as I shown, very, very quick. It was triple, all triplet. It was triplet cytogenetics. So it's not double it, triple it actually. So all the, poor cytogenetics were available for me. So number 1, pancytopenia. Number 3, extramedullary, severely extramedullary disease. So I use a formula, Dr. Maria, this is new for me maybe, A, B, C, D, E. A for albumin, B for beta, C for cytogenetics, D for LDH, E for extramedullary and extra disease. So here's all 5 factor, high 5. When you high 5, you use quadruplet, DARA quadruplet. We use DARA quadruplet, hit with hard treat, hit was hidden properly, but unfortunately, you have seen the first cycle went very well, but after third, it's not respond. Even stem cell collection was not possible, so that's why we switched something. So that's it. Yes, Doctor.
Yeah, and can I ask you a question? Yeah. Why have you not planned in this patient a cycle of conventional chemotherapy, maybe after even DARA-KRD, because of the presence of extramedullary disease, maybe the CEP or something like that, in order to reduce the tumor burden? This is just a curiosity. Is there any specific reason?
Yeah, I have answered in the case presentation. When after 3 cycles, our plan was to give ESA-PD. We sent patient for stem cell collection. We were just to start, but we got a message, stem cell that was tried, that was not collected. So stem cells was not there. So our plan was this, as patient is young, 50, our plan was to send patient to autologous. Now the thing is, we cannot say it is which is double refractory or triple refractory. What we decided, why not take out lenalidomide and don't give POMA, give cyclophosphamide to make it tumor burden down and to make it ready for stem cells. So this is our strategy. So I have shown the graph. After 2 cycles, it went down, but as third started now it's coming up. It's showing, now whatever you give. So this was the idea. Whatever you give, it may not work. Or, we have given almost quadra and penta. We have given all the penta. So whatever you give, all the things you have given. Now, maybe POMA will work or not work, maybe, may not be. Why wasting the time? And you have the good data, 50 to 70% by specific, sub-Q and all these you have mentioned. So this is how, we were thinking. But you are right. If it's not available, we will do ISA, POMA, D. But again, the patient will not go anywhere. Yes.
Yeah, and well, I've seen that you decided to go to teclistamab. I have to say that for this patient with, as you say, ultra high risk, because this is a patient with extremely poor prognosis, we reported at EHA the first data coming from the combination of teclistamab plus talquetamab. So two bispecific monoclonal antibodies together, targeting two different antigens. And I have to say that the overall response rate in patients with pure extramedullary disease was quite promising, over 90%. We are evaluating right now this combination in a specific cohort of patients with extramedullary disease. And I don't know if you are going to let us know what the outcome was for this patient treated with the teclistamab, but I can envision that the outcome was not going to be very good because this is a very poor prognostic factor, patient, sorry, and again, maybe the combination teclistamab plus talquetamab would be a bit better, but we have to realize that this patient does present a very poor prognosis.